All right, Chapter 18, Geriatric Emergencies. So a geriatric patient is someone who is older than 65 years old. We have quite a large population of geriatrics in our area. There's 52 million people in the United States older than 65, 65 or older, and it's expected to double by 2060. So we're going to have to know how to deal with these aged systems. But we also have to remember that being a geriatric is also a normal process of the human existence. Uh, Natural aging causes a decline, and typically speaking, the older you are, the more things that are going to be going wrong with your body systems. And just because a person's old doesn't mean that they don't have any mental cognition. Doesn't mean that they're not with it, right? It doesn't mean they're hard of hearing. It doesn't mean they can't see. It just means that they're elderly. Now, do some of these things happen? Absolutely. But a lot of our calls are for geriatrics that has, or that the geriatrics that have multiple issues that they need help with. Okay, so we're going to do a complete and thorough history, especially if we're called out for a medical, not a trauma. Two of the most important senses that a human has are sight and sound, right? I can hear and I can see. And unfortunately, those are two of the main things that we kind of have problems with as we age, right? And then because of these diminishing faculties, if you will, it becomes harder to drive, losing our independence, which means people be a little more cranky. Uh, it makes it hard to walk. You're tripping over things that you didn't know that weren't there because you couldn't see them. And uh, maybe I'm seeing the wrong things, like when I'm trying to take medicines. So I take the wrong medicine and I accidentally overdose. We also have the patients that are hard of hearing. It's not that they don't want to respond, it's they can't hear you to respond. They can't hear you to make that connection, right? Sometimes talking really fast will confuse them. Sometimes talking too loud, really high voices, really low voices. It really depends on the individual. And so you're going to have to start your assessment. If it doesn't appear that they're responding to you, don't just assume that they're altered mental status. Maybe they have a hearing problem. Look for clues that they have hearing aids. If they're responding to one of you that has a different uh, tenor of voice, let that person do the talking, okay? A lot of times, too, older folks don't like being wrong and they don't want to look stupid. So they'll be nodding in agreement with you, even though what you're saying is totally not true. Like, are you doing fine today? And they'll be nodding when in reality they're not doing fine. They'll be smiling when they're in pain because they don't want to be wrong. Okay, so make sure that you are speaking clearly. Make sure that you're speaking slowly, and try to cut down on all the ancillary noise all the way around. Now, don't shout at them. Okay, we don't shout at them. Hey, can you hear me, old person? We're going to start talking with them normally. We're going to look them directly in the eye, and we're going to speak slowly and clearly because many of them have adapted and can read lips. But if you're still having some difficulties communicating, even after you slow down, even after you speak clearly, then maybe, perhaps, you can use paper and pencil, depending on their dexterity of writing. I don't know sign language, but it seems to be becoming more and more prevalent. You could throw down with some sign language, but it's another language. If you can do it, great. If not, fine too. Don't know what this is. Oh, sick is the belly head. Hurt is the two fingers pointing to each other, and help is the right fist over the open hand. Okay, um, those are nice little phrases that you can, or words you can learn, I guess. Visually impaired people, including the elders, may have a service dog that is keeping them from like walking out in front of traffic. You see the people with white canes. Um, they have different kinds of eyeglasses, those things. Now, as we're doing our scene size, if we're looking for that, so if it looks like there's a harness on the animal that's next to the patient, chances are that it's a service animal that's doing something for them. Don't just assume that it's a pet. During emergencies, visual more so than auditory, people that are blind feel very vulnerable because they don't know what's coming. They have no visual clue. At least with people that are deaf, you have the visual clues that there's something going on. Um, but also with that, those that have impaired seeing, their hearing is picking up a little bit more and they're hearing more of the noises. Try to tell them what's going on, okay? Use the patient, find out the patient's name and use it to reassure them that they're not alone. Provide emotional support. If appropriate, put a hand on the shoulder, right? And then if for some reason they have to take off their glasses and it does provide help, make sure that you keep it as close to the patient as possible. Now, first things first, when you walk in, hi, my name is, and I'm here to help you today, is that okay? You're going to look directly at the patient. Speak slowly and distinctly, and explain what you're going to do in a clear, simple language. I'm going to just feel your wrist for your pulse. And you're going to listen to their responses. Now remember, when communicating with elders, it's not that they're dumb, but it takes a minute for all of the information to get in, be processed, to get back out. It's not that they're not sharp, it's just they're not as quick as uh, they used to be, okay? And proportional to themselves. We don't even know them most of the time. So we just have to be patient with some of this. I can't stress enough how important it is to maintain respectful attitudes. The very second an elder thinks that you are being disrespectful, you're going to lose all credibility. Even if you know everything there is to know, you being disrespectful is not going to have or help them to feel better. One of the other pitfalls and mistakes people make is talking about the patient in front of the patient. So rather than talking to the patient, they're talking to the caregiver, they're talking to the daughter, they're talking to the son. People that want to help, but they're getting in the way, and they do that quite frequently. You will say, "Hey, sir, how's it going today?" And the daughter from the sideline, right beside you, will, "Well, he's been doing this and he's been doing that, and blah blah blah," and cuts him off, so we can't even hear what's going on. You just say, you know, "Thank you for that information. I'm kind of assessing how he's doing. I'd like to hear it from his lips if that's okay." Um, and there are a few people that will be overbearing, um, but it's most of the time not malicious. They're trying to help. Just have them calm down a little bit. You'll do a little bit better job there. Also, as the person ages, musculoskeletal systems begin to fail. We lose strength in the muscles, and our cartilage discs and cushions everywhere lose elasticity, in which, uh, in fact, between the vertebra, uh, as they compress down, we'll actually lose height, right? And we're going to lose flexibility. That happens. It's part of the natural aging process that you really can't change. You can exercise and stave it off, but in the end, you will have most people will have some deficits. Uh, Older people lose their sense of balance and they trip into things and they fall. Uh, and then, of course, we have the osteoporosis or just the brittleness of the bones. They're far easier to break than younger people. Because of these changes, sight, sound, mobility, all of that, we have more falls, and because the fragility of the human body as it ages, there's a greater increase of breaking blood vessels and brain injuries. Okay, people naturally slow down. Help them by lending a supporting hand or arm, right? So if they want to do their, get up and move, make sure that they have some support there just to stabilize them. And make sure that you're not rushing them, right? Now, this is a normal day for geriatrics, maybe not necessarily an emergency problem, but we're going to have to make sure that we're taking care and paying attention to our patients. Listen to them to hear them, not listen to respond. Again, because of bone density, of loss of bone density, um, we have an increased possibility of fractures from relatively minor incidences, right? Typically, the most problematic for seniors are the wrists because they slip and they trip forward and they brace themselves with their hands, so they hurt the wrists. The spine and the hip because they fall on the ground and they hurt themselves, right? Uh, so those are the two main things or three main things that are broken on the elderly patients the most. And they may not actually feel pain. There'll be a deformity there, but they don't feel it because there's not enough nerve endings sending signals to the brain anymore. Typically speaking, with fractures, especially uh, with osteoporosis, we have hip fractures. Now, these typically happen in the female of the species, right? Um, yes, they do happen to males, but for the most part, more frequently, they happen in the older women. Uh, and typically speaking, when the hip fractures, um, it the toes are generally rotated outward. So the side of the break, the toes will rotate flat, going laterally, and might see a little shortening. Um, if you have a fractured femur, it will be rotated in and shortened. We want to treat these patients gently but quickly and get them transported out because they could be bleeding out inside. Hearing loss, sight loss, can't feel things, so maybe I burned myself. I can't move as quick, so I couldn't get out of the way. Uh, Fractures, the one that is, I think, probably the scariest is senility, where you're not mentally in charge of your faculties. I guess I don't know which would be worse, not knowing that you don't know or knowing that you don't know. Loss of bladder or bowel control, just because the muscle tone is, you don't have as much strength as you did before. Also, as you get older, typically you have more and more problems, and you have more and more problems because your body is less apt, less able to defend itself against diseases. So they're going to have weakened immune systems. They're not able to cough as effectively, so they can't clear the phlegm and the grossness out of their lungs, which increases pneumonia chances. And they can't like cough that out, spit it out. They can't move their what they normally used to clear their airway, and so we'll see some problems there. Increase of cardiovascular disease because again everything is hardening down as it ages. Everything becomes more rigid and more brittle, right? The heart can't speed up like it used to, and the vessels become stiffer, typically because of the fatty deposits from all the years of bacon and grease that we put through our systems. Um, Again, as well as being geriatric, it increases the possibility of heart attacks, angina, congestive heart failure, that kind of thing. Along with that, with arteries in different areas, we might have the increase of hemorrhagic strokes or occlusive strokes in the brain. The triple A, very nasty little bugger that, typically speaking, if you blow an aneurysm as an elder, you're pretty much toast. But along with that, you can fracture the aorta. We don't think about fracturing vessels, but as they age and it's more brittle, especially when we're talking about trauma, we might see a fractured or a ruptured aorta because of trauma, right? In typically speaking, with chest pains or with cardiac events or even respiratory events, the patient may not have appropriate signals being sent to the brain to say, hey, I'm having a hard time breathing. Hey, I'm having a hard time with my heart. because the nerve endings in those areas have diminished in receptivity over time, right? So whenever we're treating an elder patient, anybody over the age of 65, we have got to be very hyper aware of, is this truly what's going on here? Or is there something underlying that I'm not seeing and it's being masked because of the geriatricness? Uh, so now on the respiratory side for the elderly, uh, as the patient ages, the alveoli again lose some of their elasticity. Just think about this. It's like we're quickcrete cement that is hardening over time, and the more age we gain, the stiffer we get, right? And so we have to keep moving around. We have to keep breathing deeply. But the alveoli and their muscles associated with breathing become weaker because we're not training our bodies as hard as we used to in our youth. We used to run around, right? Well, we don't run around typically in our age. So we start coming up along respiratory diseases, right? Now, there's two major types of respiratory diseases, and we've already talked about these in the respiratory emergencies. But you have chronic respiratory diseases, things that I have had for a long time. Chronic means a long time. And there's acute respiratory diseases, things that happen suddenly, right? And so, which one are we dealing with, right? And what have you tried to fix it? What can I do to help you with that, right? We've got the chronic things like chronic bronchitis, emphysema, that type of thing, and we've got the acute things like asthma, right? And pneumonia is kind of acute, kind of chronic, depends on how fast it comes on a person. People with COPD have this condition and may have it for quite some time. And anything else that's added to their mix, a cold, a cough, another infection, can result in very quickly making this a lethal issue, even though chronic obstructive pulmonary disease, COPD, is something they've had for a while, right? But pneumonia is one of those main things that comes out for the older adults. It's just that because they're not clearing their airway, they're not clearing their lungs from all that mucus and other junk. It just sits down there, and infection and bacteria grow. Right now, any elder that's got a fever needs to go in. Typically, we're looking at some sort of a pneumonia or systemic failure. And we've got to stay out ahead of this so that they can get better and get back out in the world and stay strong. What are we going to do for these patients? Well, for any of these patients, we're going to examine them carefully. We're going to listen to those lung sounds, right? We're going to treat any signs and symptoms as best as humanly possible, and we're going to make sure that transport's not far away. We don't want to be sitting there hem-hawing whether we should go to the hospital or not. Now, remember that we are the first responders on scene to kind of push this along. So we need to make sure that we're being patient advocates, getting those ambulances, those transport units on scene for them. Now, it seems like it used to only be elders with cancer, but now we have cancer on all the ages, it seems like everywhere. But with these cancer things, patients will call for help with complications for cancer. We may not even transport. Maybe they're weak and they need help transferring from the bed to the chair to the bed or the bathroom or whatever else. But it also might be with all of a sudden I have pain, I can't move, I can't breathe. And even though they know they have cancer and maybe it's even terminal, they're not prepared mentally for it and they need some help. And so we'll be responding up there. The biggest thing here is compassion, right? And if so noted and they want to, make sure that you're arranging for transport. Altered mental status. The number one reason for altered mental status, number one across the board, is not enough oxygen to the brain. Right? Remember that in normal physiology, a normal brain needs oxygen, it needs glucose, and it needs enough water. All three of which are altered in the geriatric patient. So when I don't have enough oxygen, I'm not going to be thinking straight. I may be talking to you, but it's not going to make sense. Low blood sugar, same thing, right? Now they're talking about being cold here as well, the hypothermia. Uh, have you ever been to a geriatric's house and it's like 95 degrees in there? That's because their body, their skin is incapable or not capable of controlling the heat regulation anymore. And so they're going to lizard-like conditions, and a normal body is 98.6, and so they're trying to get their body up to 98.6. Problem is, you're visiting and you're sweating your keister off. Whatever the problem is, if they're cold, give them a blanket, maybe give them some warm packs. Um, Low blood sugar, give them sugar. Give them oxygen. I mean, these are fixes that we know how to do, right? Now, again, with medicines, many older people take a lot of medicines every single day. I don't perceive myself as being very old, and yet I take two medicines, and not counting my vitamins and other things that I take, homeopathic things. And not only that, they see several different doctors prescribing them several different things for each of these, and sometimes the those medicines and those treatment plans are mutually exclusive, and they don't do well for the patients. So we need to make sure that number one, the patient is what medicines do you take every single day? Have you taken your medicines? Where are they at? So I can take a look at the instructions, that type of thing, so that you can give a good handoff report to the transport unit. Typically speaking, the pharmacist will keep an eye on that, especially if they're filling it in the same place. But the problem comes in when they fill at different pharmacies for different problems, and it might take a minute for them to get everything in one spot to understand what's going on. If they have a bag of medicines or if they have a list of medicines that they take, make sure they get transported with the patient as they go to the hospital. Now, again, because they have an altered immune system where it's starting to fail with age, it's easier for them to get all kinds of bacteria, virus, and fungi going on there, causing different body systems and parts of the body to fail. And the main signs, symptoms, if you will be fever and fatigue. I'm tired all the time. Maybe I've got a light fever, a low grade fever, like a 99 or 100. Coughing, and muscle aches, and diarrhea. Things that we wouldn't, as a middle-aged person or a younger, probably wouldn't give a second thought to. But now we're getting beat up with this infections and sepsis, and uh, it could be very critical to them. So we've got to make sure that we're paying attention. It is, for the elder, a potentially life-threatening complication of infection. Sepsis is. So they get a cut, they don't keep it clean, they can't feel that it's hurting. They can't really maneuver to take care of their own bandaging, and it gets infected. Now, when this becomes worse and the infection gets worse, seeps into the bloodstream, and it causes more problems. Uh, the body attempts to fight it, but in fighting it, it creates more junk in the system. If they don't have enough fluids there to rinse it out, well, then we got more and more uh, infection building up rather than getting rid of it. And as septic shock gets worse, especially in the elder, we could see them spiral into irreversible shock, and that'll be the end of them. Anytime we see signs and symptoms of an infection, we got to send the patient, talk them into going. This is the 25th time and they're tired of going, but hey, this is an infection. You have a fever. You're not doing well. You staying home is only going to make it worse. It's not going to make it better. Get them to go to the hospital. Now, there are patients who require long-term care. Now, these might be the patients that are in nursing homes, but they might be at home with in-home nurses and family around them. Again, could be a ton of different medical devices, ventilators, oxygen devices, surgically inserted tubes into their throat, monitors, and so forth. If I don't know how to use these pieces of equipment, I'm going to rely upon the patient's family for this, because I may not know these devices, and pretending I do could actually wind up hurting them. You might have pacemakers, internal or external tubes, catheter drains, all kinds of things. And most of the time, these people that have all these advanced machines, they've got a lot of medicines to keep them going. Uh, this you see here, this gentleman is sitting on a in-home ventilator that goes into the tracheotomy there in picture A. I was just visiting with a lady yesterday that has this. She sleeps with this machine on during the day. She doesn't need to have it, right? And the fella on the right in B, that is a feeding tube. Same lady had this as well. So she's in pretty bad shape. Rather than eating, because it's hard to make the mouth muscles do what you want it to do without choking, you just get fed through this port into the stomach, so you don't have to eat anything. It goes in that way. Now remember, you are an EMR. You are the first on scene for an emergency, not necessarily a long-term care issue. So why am I here today? Well, as soon as they start describing the long-term problem, be kind and receptive, but what's the emergency? Why am I here today? And we're going to help them with whatever it is that they're help today. Again, if it is something like moving to the toilet or whatever, maybe we need to see about getting them in touch with the appropriate services, because emergency medical care is not moving them to the toilet or back. That's compassionate care, but we're taking ourselves out of service to do that. So we got to make sure that we have the appropriate resources dispatched to what needs to go on, right? But please don't become overwhelmed or distracted by all of the things that they're hooked up to, all of the things that are going wrong with them. Because some of the times we can get compassion overload. I want to care for you so much that I neglected to take care of the emergency in the moment. Make sure that you're making some good questions, what's going on here. And in reality, we're probably going to be there a few minutes before the next level of EMS gets there. So, don't become too entrenched with what's going on long-term care here. What can I do in the emergency moment? Now, many elderly suffer from depression. Actually, a lot of people do. But in the elderly, it's the most common psychiatric condition. Now, depression sets in because they're by themselves. They're isolated. And then depression sets in up to 13%, 14% almost, when you lose some independence. You lose the ability to drive. You lose the ability to live on your own, right? Uh, and this says that it's more common in women than men. Well, that's because women live longer, quite frankly. And the statistics show, that while men are starting to live longer on the average, the reason it affects more women is because more women are alive at that age. Now, things that could cause a spiral out into depression farther is they get moved into a nursing home. Again, losing their independence, or they're at home and no one comes around. And they're basically a prisoner in their own home. That could be reasons for that, the depression to get worse. How about this one? The loss of a spouse or a close friend, especially after years and years and years and years and years and years of friendship, right? Or how about this? You are an elder who is 100. My great grandmother lived to be 102 and a half. And she lost not one, not two, but she was losing her third set of friends due to age and illness. She lost all of her children except one before. So there was one child still alive out of all of her children and grandchildren. The children and stepchildren, not stepchildren, children-in-law, in all of the family, that generation had passed away except one before she left. So that's a depressive moment as well. Think about those things when you're communicating with them. I'm getting sick. I'm sick all the time. I've got a terminal disease that's going to get me, right? That's a reason for depression. So those feelings of sadness and despair we've got to be aware of, and we're not trained mental therapists, right? Even the paramedics are not trained mental therapists, but we can be compassionate. Why am I here today? Let's take care of that, and maybe you can get them in touch with some resources for them. Elderly men have the highest suicide rate in any group in the United States because elderly men cannot resolve in their minds that um, they're weaker than they used to be. They're mentally unstable. They're not as mentally sharp as they used to be, and because of that, and the perception that they have nothing left to give, they end it. Now, again, it could be any one of these other contributing factors that assists that. I've got a physical illness, especially terminal ones. I've lost my wife. Uh, I'm drinking badly right now, and along with these other ideations, is the reason for them to take this drastic measure. So when we're dealing with elderly male patients, make sure that we're listening carefully to what they're saying. Uh, men operate, uh, most men operate on a respect-driven communication style, and if if anybody is being disrespected or denigrated, eh, you may not get to what you need, and as far as helping them, you may see later on that because of our inactions that they take some drastic measures. So we always want to be paying attention for signs of hopelessness, depression. Have you tried suicide in the past? Probably one of the most powerful movies I've seen recently is called Otto, and it's of an elderly gentleman who lost his wife, and he wants to go be with her. And he's got a condition that is lethal. It's going to get him in the end, and he decides that he's going to try to kill himself. And he tries 3 different times during this movie to do that, and yet there is a very attentive neighbor that kept trying to draw him back into the world and be there for him, and it was a positive movie, a very powerful movie. If you suspect a patient may be considering suicide, well, now we have that time where we have to intervene. And dementia, that is an insidious problem with the brain, and we have to. Why are they having altered mental status? Is it their baseline because they're degrading, or is it because of lack of oxygen, or is it because of lack of glucose? Are they dehydrated? Why are they not acting correctly? Now, as dementia sets in, it is a pattern of decline, right? So we're going to understand this from talking to the patient's loved ones or caregivers, right? The reasoning is off, their judgment is off, they're not comprehending what you're saying, at least completely, and they can't talk very well. They're not communicating back to you. Again, are they having a hard time hearing? If that's the issue, then we're going to have to take steps to correct that. 20 to 40% of people older than 85 years old have some degree of dementia. That's crazy thinking. You know? That is crazy. Better than a third of the population over the age of 85 have some form of dementia, right? How does that happen? Small strokes, again with the hardening and the narrowing of the arteries, this time especially leading to the brain. And maybe they just have a family history of dementia, Alzheimer's, that type of thing. Alzheimer's is the most common of the dementia type problems, but it is not the only one. It's degenerative, though. uh, far more than other things. Most of the time, it attacks the memory centers. Behavior is also involved, and they can't think. And sometimes there's glimpses of their old selves that pop up, and it's in those moments they realize they're having a problem, and that's where you will have anger and maybe even suicidal ideations. So be aware of that and be kind and compassionate. Yelling and making them try to remember is all that will do, will frustrate them and you. So just be there for them in that moment. At the very end of Alzheimer's, the brain is in complete shutdown and everything doesn't work. Okay? Can't walk, can't control they don't know how to control their bowels anymore. Their brain is in full shutdown mode, and they can't even swallow. So as they progress into this moment, we're you know we're in supportive care only at this point. But when you're dealing with any kind of dementia patient, if you know their name, use their name. Speak it with a firmness that penetrates their haze. Um, the power of their name will get through to them. At least they'll look at you, and maybe you can get some things. Put some compassion in there, and and even through the haze of dementia, the compassion will always shine through. Going to have to rely on family members. And you see this little old lady here, she's got a hand on the rescuer. Many of them are just looking for some kind of connection. I need somebody to love me. I need someone to care for me. Will you help me? Right? So kindness and compassion, I can't overstate it. That's how we're going to get this through. And the family members seeing you being kind and compassionate will help them with their stress because they know that there's no end to this, and they want only the best for their loved ones. There does come a point where the end of life is all but assured. I mean, we all know that we're not getting out of this life alive. But when we enter hospice care, it is the final statement of going, I'm entering into this, or my family's helped me decide that we're entering into this because there's nothing more we can do, and I'm just going to be comfortable now for the rest of my days. So in this moment, physical, emotional, spiritual, social, economic care for these patients, and they're pretty much um, based on other patients of similar nature. They've got about 6 months or less to last. Um, so once a person enters hospice care, that's pretty much the end of it. But that doesn't mean we just walk away like, oh, they're in hospice. That's too bad for them. But we need to make sure that everybody is working together to bring dignity to this patient over the next months, weeks, days, maybe even. Most of the time, they're getting pain relief for their maladies, whatever they may be, and you might see some variety of issues with that pain medicine. Sleepiness, grogginess. They don't breathe very well. They have a decreased breathing pattern with an overdose. So we have to be ready for those type of things, right? I'm going to make sure that I counterbalance that pain agent at least enough so that it can breathe again. But again, with the lady I was just talking about, she's on some pretty massive doses of morphine every 2 hours just to keep the pain down. She's in hospice care now and not expected to live more than a couple of weeks. Whatever you do, make sure you're documenting. Now, advanced directives are a documentation of what the patient wants in the end of their life, right? So, and it may include do not resuscitate. I don't want you to start CPR. I don't want you to save my life. If I go, let me go. It's my time. Um, there's also most orders, medical orders for life-sustaining treatment. Here's what you can do, right? But the advanced directives, whatever they are, need to be witnessed by the appropriate doctor and patient or patient's representative, patient's proxy. These papers need to be present. Without these papers, you err on the side of life. Well, they've got a DNR, but I can't find it. Well, I'm sorry, that's not. I'm sorry, but we have to help them right now. Please find that piece of paper so we can get started, so we can do what the patient wishes. Right? We need to make sure that you're keeping track of these documents. You need to know the regulations. What do I do in the event of? So take a look at some examples online of these advanced directives, of these DNRs, and what does that mean for us, right? And if we have any question at all, we put it back on the hospital. Call the hospital, call them on the HERN and say, hey, hospital, uh, this is EMR so-and-so. I'm on scene with Grandma Grunt here. And I've got this piece of paper that looks like a DNR, but I can't understand it. Do you have a record of this? What do you suggest? And leave that to the doctors to figure out, and then document that. All right, this section here, I don't understand, number one, um, but it does happen. So when we talk about elder abuse, it's much like child abuse. It is somebody that can't care for themselves that's being beaten upon, right? Typically, when we're talking about older adults, maybe they don't have physical or mental capabilities to withstand physical onslaughts. And unfortunately, it can be perpetrated and is most often perpetrated by people they know, spouses and friends and caregivers. You know, stop pooping your pants. That's disgusting, and they get smacked, or they get pushed, or they get shoved, or maybe this is payback for when they were kids, or whatever. We see elder abuse in all kinds of things: physical, sexual, emotional. You know, maybe I don't lay a hand on them, but just a constant berating of them. You're toxic. You're terrible. You're this. You're that. And abused financially. You know, you're terrible unless you give me $1,000. You're horrible unless you let me live your rent free. That type of thing. And it's a terrible thing to do to an elder, anybody. But the elders just want peace. Signs and symptoms of abuse, much like anything else: bruises, burns, trauma. Signs of neglect, like dirty, they're filthy. Um, this lady here obviously was hit very hard in the head, and that's very dangerous because again they're brittle. We might see cigarette burns, um, multiple different bruises in multiple states of healing, uh, face, head, neck, hands. If you suspect elder abuse, you need to report it right away and make sure that the appropriate authorities are responding. There are many agencies out there, senior agencies, that can assist with, helping the patients with physical assistance, with nutritional support, emotional support. There's elder uh, day centers where they can go for the day and be in community and play games and have emotional support. Make sure that these people are tied into that. Okay, so as a summary to chapter 18, let's just talk about remembering that natural aging is a natural process. Unfortunately, that means degradation of sensory and musculoskeletal systems, all systems really. And fractures become more and more prevalent, especially because of the bone density loss and then the osteoporosis type things. Osteoporosis being more a female issue. Uh, Common issues for the elder: cardiovascular respiratory diseases, again because of the failing systems. If they're in an altered mental status, is it because of lack of oxygen to the brain? Is it low blood glucose? Are they cold? Remember that many older patients have long-term issues that need to be cared for. Don't overlook signs of mental health. We have depression, suicidal thoughts, and dementia. All of these things could interweave. Don't ignore them and go, oh, that's just because they're old. And please don't turn a blind eye to elder abuse. Don't explain it away by accidents. Be vigilant across the board for your patient. All right, that's chapter 18, Geriatric Emergencies.